الو.
الو يا بروف، كيفك؟
سلام مروة، كيفك؟
الحمد لله. الصوت واضح والصورة واضحة.
لا خلاص تمام. This is good. Now it's almost 11 o'clock. There's some 1 minute more and we will start business. طيب بسم الله الرحمن الرحيم. Welcome all for this new lecture on infectious and tropical diseases. And I think by now we have almost completed quite a bit of the course, almost 80%, 85% of what I intended to provide information for you. But I would like addressing all my students in batch 26, maybe other students are joining. I would like to thank all those who are helping us with the online teaching. Just been on phone with Dina, the leader of the group, and she affirmed that Ali Abdelal from Birmingham, a consultant in acute medicine, is going to join, giving lectures on the acute part of medicine. Brahim of the surgery is doing well. Atif Fazari on obstetrics and gynecology is doing fine. Ali Arabi, who is Professor Ali, is a renowned pediatrician. He's also contributing, and hopefully we'll have Ahmed Bashandi, who is one of our graduates, will also join in orthopedics. Isra, who is also a graduate of our student, also is giving the therapeutics. So I was telling Dina that really you are lucky to have all diverse teachers from all over the world to give you the best of their knowledge. So this is one thing. She asked about on face-to-face teaching, and we will plan, inshallah, once the university here starts, I will plan to have teachers face-to-face on concentration. I will, if I'm available in Rwanda, I also would like to take part in the face-to-face teaching. We are nostalgic for seeing the students in front of us, and interacting with them, asking, why are you sleeping? Why are you not responding? Some of them are. It's the joy of education to have face-to-face teaching. But let us make the best out of what is available. Okay, in this lecture, I divided into two parts. The first part is fever, and the second part is rabies. Okay, they have no connection, but I thought I will give the important part of each section so that in the coming weeks we can wrap up all the lectures on infectious and tropical diseases. Hopefully, if Arwa with experts would like to put these lectures on the YouTube, it will be available for all who are interested. Okay, fever is a very common symptom. Let us face it, it is one of the commonest. Maybe after cough, which is the commonest by a lot. Fever is a symptom which has to be ascertained by measuring the temperature. Okay, and measuring the temperature is important. We have 4 sites which are recognized under the tongue, the skin, which is from a distance, and then we have the axillary, the same thermometer on the axilla, and then we have the rectum, which is for children, especially young children. So making a diagnosis of fever is not acceptable except if you have a temperature to register. It is known that most of the fevers have periods of afebrile phases, afebrile phases. So it may be that the patient, when it comes to the clinic, may be afebrile completely, and if you do the temperature, it's going to be normal. So bear that in mind. And if the patient is educated, you can give him a thermometer and then he registers the fever. Okay, what is the importance of the pattern of fever? Our aim of this lecture is to try to find a quick way of diagnosing fever. Okay, definitely if you have a temperature, then you will know the diurnal variation, if it is morning or evening, if it is intermittent or remittent. Okay, this is the difference between intermittent and remittent. One is, you get completely back to normal, and one is just a decrease of 1 degree centigrade or so. Continuous fever, you have maybe that the fever could be continuous, and continuous does not mean 24 hours. It's more of the day, more of the day. You can even have malaria fever, which is tertian meaning every third day, or quartan every fourth day. But this pattern is academically interesting, but in diagnosis is not very useful because of two reasons. The reason one is documentation of the fever is not easy. Nowadays, we don't admit patients with fever, except if they are very ill, if there are other symptoms with it. But otherwise, we do it as an outpatient. Hence, we wouldn't have the chance of recording the temperature all day. We used to record the temperature every 4 hours, for the whole day, for a week, and then we see the pattern, if it is that of Kala-Azar or typhoid. But nowadays, with the advancement of diagnosis, laboratory diagnosis, diagnostic, immunological diagnosis, then I think most of the fevers can be diagnosed as an outpatient. So this is so the diurnal pattern is not all that helpful. Rigors. What is rigors? Rigors is uncontrollable chills, or shivering. Okay, it's classically seen with malaria. It's also seen with urinary tract infection and other viruses like dengue fever and Lassa fever will also have this one. But among the bacterial infections, brucellosis is one of can give you sometimes regulation, but more so it gives drench of sweating. Okay, so rigors, shivering, uncontrolled shivering, or chills, and then drench of sweating. All fevers have sweating, and they resolve. Once you sweat, it's resolved. Particularly in malaria, people feel like resting after they have the sweating. Okay, so malaria is one, give you heavy sweating. Tuberculosis is another one, and brucellosis will give you another tragedy. It's not very diagnostic of any big disease, but in my practice, if I see patients with sweating tremendously, especially at night, I think of tuberculosis. Day and night is think of brucellosis, and malaria is, have other symptoms and signs which are more specific to malaria. But again, the range of sweating can occur. Okay, it's what we think is that children have a different pattern, of fevers. Like children who are less than 3 months, they don't show the temperature. They don't they don't record the temperature high, and they may present with other symptoms. Like even in meningitis, you can have no fever, but the child will be tuberose, lethargic, and maybe into coma. So that is a different kettle of fish. Okay. The non-localizing, other non-localizing features, meaning that if you have, say, a cough, for instance, okay, a cough that is and sputum, maybe green sputum, then that is maybe a lung abscess, okay, or bronchiectasis. If you have rusty sputum, you may think of pneumonia. Okay, if you have blood in the sputum, then you have to think of tuberculosis. Enteritis, watery diarrhea, abdominal pain, then a sore throat, for this is again localizing for pharyngitis or tonsillitis. Then meningitis clearly is tuberose, comatose, or drowsiness, but most important, neck stiffness, which is meningism, and meningism can occur with encephalitis or bacterial infection. This is the commonest. Tuberculous infection, and some viral infections can give meningism, which is meningitis. Obviously, the other localizing feature is Kernig sign. Kernig sign is flex at the hip and then extend the knees while the hip is flexed, and the patient usually is caught up with pain at the back after you are stretching on the meninges. So these are what we call localizing signs. And this is definitely based on good history and good clinical examination. Then investigation. We used to have what we call PUO, or pyrexia of unknown origin, or FUO, fever of unascertained origin, meaning that we have fever, but up to now we have not diagnosed it. And we cannot say this except after 3 weeks. If the fever continues defying our diagnosis for 3 weeks, then we can call it of unascertained or unknown cause. But this is getting less and less because of the good laboratory we have. In addition of the microscopy and the immunological, we have the very advanced technique of immune testing, antibodies and antigen, which are now becoming more specific and more accurate. So, and on top of that, we have imaging. So we think of whatever deep-seated focus of an abscess or a small tumor, it can be picked up by MRI or CT scan. So this piece of unknown or unrecognized causes is getting less and less. So it is just reflecting our inability. PUO is reflecting our inability to diagnose. It's every cause of fever should have a cause, but these are when non-localizing signs. Okay, for instance, Kernig sign is very clear for meningitis. Maybe abscess, you have an intercostal tenderness, but sometimes you can have a very small lesion. Okay, so these fevers which used to defy diagnosis are hypernephroma, malignancy, lymphoma, when the lymph nodes are not superficial, intra-aortic or in the higher region. So these are defined diagnosed because they are not showing as clinical signs, but now with the investigations available to us we can diagnose almost all fevers within a reasonable time. But be aware that some fevers are difficult. Okay, I would like to touch on febrile convulsions, although I'm not a pediatrician, But I think febrile convulsions represent some important features in our thinking. Okay, number one, it is the prevalence of it, age determinant, okay, of the convulsions, and the sequelae which comes out from febrile convulsions. Okay, febrile convulsions is diagnosed or is defined as tonic or clonic seizures, which last up to 5 minutes. Definition is important, and the age is important, okay? And the convulsions occur during the fever, okay? The age is 6 months to 6 years. If it occurs before 6 months, then you have to think of other causes as well. If it occurs after 6 years, then you have to think about causes like encephalitis, meningitis, and all the rest of it. But 6 this is the age. Okay. The important thing is a benign condition. Although there is a scare, the patient, is convulsing, all the family is alerted, the anxiety over, and the child may pee or urinate. But the end result, when it settles down, may come frequently, but the patient will recover completely without neurological deficit. And this is important. This is why, if we think if the convulsions continue for a longer period, more than 5 minutes, maybe up to 30 minutes, then this is something more organic, like encephalitis, brain abscess, and meningitis. So it's the time is important, the age is important, the type, the duration is important, and reassurance of the patient is essential, because the question will come to the mother is he going to be with a cerebral deficit? That's the most important part. Okay, this is febrile convulsions. It just came on my way, so that just to point out that age may be important. And neonates are known not to show temperature. If they have an infection, they may not show any temperature or any fever. So it is important that we should consider the different ages. Okay, having said that, elderly people also will have a depressed reflection of the infection. They may have less fever. And the fluctuation of temperature in the elderly is important, because the elderly can go down to hypothermic level very easily. So age here, not only the lower age, children and neonates, but also in the old age. Secondly, you have always to remember patients who have immunosuppression. And now these patients are increasing in number. Corticosteroids, immunosuppressive for cancer, and then classically is the HIV. Okay, once HIV came in the 80s, it really changed our thinking and our understanding of the effect of low immunity. We used to have low immunity because of congenital, but this is acquired low immunity of the virus. So the fever, the type of infection is different. The appearance of the fever is different. Suppression, you may get no fever with infection, severe infection. So bear in mind the categorization of different patients. So children, neonates, elderly, patients with suppression of immunity, HIV, and even patients with malnutrition. They may not show that classical temperature going up. Okay, as a tip for diagnosis, after you have had a good clinical picture, history and clinical examination, look for localization. Well, the thing which we already did, examine the chest, look into the liver, if there is intercostal tenderness like an abscess or maybe liver abscess, abdomen tenderness, and you may have a fever for a surgical condition like appendicitis. Okay, people with fever and then abdominal pain. And if you go to the right iliac fossa, you may feel pain on pressure, but rebound tenderness, again indicating maybe appendicitis. So it's this localized design will help. All right. What are the tests? If I'm in just a family medicine center, okay, what are the simple tests which can diagnose fever? The important thing is we go for the simple test, and then we should understand what is the outcome of these tests. If you do, for instance, white blood count and you don't know what is leukopenia indicates, what is lymphocytosis indicates, then it's a useless test. So we know simple tests, but these can uncover quite a number of causes of fever. For instance, white blood count, very useful, very simple, can be done in any hospital, maybe in any health center. If you have polymorph nucleosides increase, then this is more of an infection. If you have a lymphocytosis, more of a viral infection. Okay, if you have leukopenia at some stage, this indicates either typhoid fever, brucellosis, or Kala-Azar. These are the three. Remember, we have fever with leukopenia. These are typhoid fever, brucellosis, and Kala-Azar. But anyway, if there is an super added infection, then the picture will be different. Again, if you have eosinophils, all right, eosinophilia, then this indicates some parasitic infection. And you remember, we talked about salmonellosis, okay, fever, which again is one of the difficult ones to diagnose and maybe coming under POO, because you diagnose Salmonella typhi in the blood, but you treat it, but then it recurs because, as we said, that the bacilli of salmonellosis inhabits the tegmentum, the mouth of the schistosomes. So they live there, and they cough and they vomit the bacteria from time to time, giving you septicemia due to salmonellosis. Once you see it, you culture it, you treat it, but then you are not treating the origin of the mine of which ushers the bacilli. And this is why we recommend that patients with salmonella who is not being, responsive very rapidly to antibacterial, then you have to seek a cause, which is maybe schistosomiasis. Once you treat that with praziquantel, you get everything settling. Okay, the fever should be looked into something. If the patient is mobile, going around, then you will have a leisure of good diagnosis. But if the patient is very ill, vomiting, diarrhea, dehydrated, then that is a hospital case. And then maybe that the patient will go into tuberose, comatose, disorientation, and then they go into more difficulty of hypoglycemia, and then high lactate level, and then you have the difficult situation of coagulopathy, intravascular coagulopathy, in fact, with low platelets and then bleeding. Okay, this brings me to sepsis. Okay, to sepsis. Sepsis is defined as a condition whereby there is generalized infection by mostly bacteria but there is an inflammatory response, systemic inflammatory response, and organ dysfunction. These are the three criteria. Sepsis, we used to call it septicemia, which is not the right word now. It's septicemia. Sepsis is a generalized infection, bacteria all over, which is inviting a lot of inflammatory response. And you remember that part of the disease is caused by the infection, but part of the disease is also caused by the response of the body, the inflammatory response of the body to the infection. So that is the second criteria. The third is you get organ dysfunction. It is a serious condition. Once we get sepsis, some organ dysfunction, then this is an emergency of top rank emergency, and most of those who get sepsis end into ICU, intensive care unit, and needing intensive care. Okay, feeding, urination, and then identification of the bacteria, and then support for the organs. You get the support for lungs, ventilation, and then you get support maybe for the kidneys if they fail. Then you get support for feeding, another one which is important and sometimes neglected. And then the coagulopathy. If you reach a coagulopathy stage, which is bleeding, intravascular coagulopathy or consumption coagulopathy, then this is serious. Okay, people will be lucky if they have a bacteria that can respond to antibiotics. So it's an emergency in diagnosis, emergency in treatment, and even before the culture, people has to use strong antibiotics to limit the infection. Okay. But PUO, apart from the majority of fevers is due to infection, and majority within the infection is due to bacteria, but other viruses, other microbes like viruses can also lead to fever, like Epstein-Barr virus, giving you infectious mononucleosis, even AIDS because of the superinfection. All the children viruses will give you fever, like poliomyelitis, measles, chickenpox. These are viruses. And the hepatitis, we dealt with that. Hepatitis A, B, hepatitis A and E, which give infectious hepatitis or epidemic hepatitis, and then will give you the more serious hepatitis. These can also have fever as a symptom. So please think of a fever as a symptom, not a disease. Number one, look for localizing signs for the cause of fever. And then three, start with simple tests like white count, urine test, okay? And then if you are in doubt, do the platelets, and then proceed to more tests like cultures of urine or cultures of the blood, and then look for the patient if there is any change in signs. Okay. In typhoid fever, you remember we said that the spleen will get enlarged in the second week. So if you see a patient with typhoid fever and it's very sweet, and you think that spleen is a muscle of typhoid, you miss the diagnosis. So the phases of appearance of the physical signs is again important in diagnosis of fever. Okay, we used to admit patients with fever, but nowadays rarely we do so unless it becomes a chronic fever or a PUO, or we are looking for changes in the physical signs. Okay, a patient with lymphoma may come with fever. A patient with hypernephroma or renal cell carcinoma can come with fever. They may not be apparent on physical examination, but you have to have a way of putting them into the focus. As soon as you know, if you do the basics and you do the rest, then you have to think of deep causes. If I'm to divide the cause of fever, then the bulk is bacterial and virus, then inflammatory, okay, like immune inflammatory, like SLE, rheumatoid arthritis, polyarthritis, nodosa, and all the inflammatory diseases. And then third is neoplasm. And among neoplasm, the two which may defy early diagnosis is the cellular, the kidney, and the lymphoma. But other malignancies can cause fever and can be hidden unless you are following the patients for change of physical signs. Once you see lymph nodes appearing externally, then right up, that is maybe lymphoma. Tuberculosis of the bone is again need to be thought of. It can give fever. And then joint pains, it can do a lot of damage. I had a child, a grandchild, who had fever, and people were thinking of big immunological diseases like Takayasa syndrome and all the rest, which is very serious. And they have been investigating almost everything. She was given immunoglobulins, but at the end of the day, it became E. coli urinary tract infection. Very simple. Okay, so if you have any symptoms relating to the urine, like dysuria, urgency, and then change of color of the urine, then that is the entrance to your diagnosis. You can take the urine, you examine it for polymorphs, and then you send it for culture. Even the smell of the urine can be changed, and this is a way maybe of help in diagnosis. So please think of the different causes of fever, try to categorize them, try to think what is the best approach, clinical examination and investigations before you go into the deep causes or the deep causes of fever. So that is about fever, and I hope that will cover at least this is a stimulation of to think about fever, which is very common. Okay, you may not be seeing a lot of fevers because you are being taught in the wards, and admission of febrile patients is not very common. But if you go to the outpatient, or if you go to a family physician center, then many people will come with fever, maybe simple or malaria. Infections can be treated as an outpatient or needing some more investigation. And then the investigations has to be simple, and then you go on. If you have evidence of whatever, then you do the other common investigations. Very much dependent, the cause is dependent on the region where you are, in tropical areas or non-tropical areas, and the age of the patient, as we said, neonates, people who have 6 to 6 convulsions, and then people who have immune deficiency, malnourished, HIV, AIDS, and the rest, elderly people, and then physical examination repeatedly to see if there are change of signs. And this is important. I'll give you a hint. Okay, you may do all the tests, immunological and otherwise, and nothing comes out. But suddenly you feel a liver which has not been there. You feel intercostal tenderness, which has not been there, and then a diagnosis of liver abscess comes very clear. So that is about fever. The other half of the lecture, as I promised, I will talk about rabies. Rabies is not taught quite a lot because we don't see cases, in the world. It's not a chronic illness; it's an acute illness, and this is why if you have a patient with rabies, it's in quarantine. It will be put in a quarantine because saliva of that patient, if it falls on a wound or abrasion on the skin of somebody, then the saliva may give the virus to another one, and this is dangerous. Anyway, rabies, as you know very clearly, it's a zoonotic disease, comes 99% from dogs. And in certain areas like Caribbean and Amazon, it comes from vampire or bats, caves bats. To the extent that if you go and find bats anywhere in the world, you have to suspect that it contains the rabies virus. Reservoirs is usually wild animals like jackals, foxes, and the rest. Okay, the virus is a neurovirus. Very interesting, these viruses. Why do viruses select liver, like hepatitis B, A, C, and E? Okay, why do viruses like rabies sit on nothing but neurons? Okay, why are viruses sit on the anterior horn cell, like poliomyelitis virus? So these viruses are very intriguing. Okay, what attracts them to that tissue? Rabies is exclusively a neurovirus, and it causes encephalomyelitis. Encephalo meaning referring to the brain. Myelitis is the spinal cord. It is a disease which is universally fatal. If a patient is being diagnosed as having rabies, then that is a death certificate, because very rarely, not rare, almost unknown, that a patient who has rabies will come out of it. There are only 3 cases reported in the world, and there is suspicion about if they were having rabies or not. So for all practical reasons, I think you can go away with the concept that this virus can kill immediately. Okay, the virus is a neurovirus. Okay, it's a type of Lyssa virus. And Lyssa is LYSSA virus, Lyssa virus. And usually I spell it because these words sometimes are being pronounced differently from American English to the British English, but it is LY. So it's, if you get it, Lisa or Lyssa. So it's a Lyssa virus. Okay. The second important thing, if you are bitten by a dog and we are given post-exposure prophylaxis, what we call PEP, okay? PEP, just like the post-exposure to HIV/AIDS. If you have a pinprick with an infected needle, then we give you a post-exposure, and after exposure, we give you prophylaxis. And if you give the prophylaxis very early, it's almost 100% protective. So the important thing is it's a rabies virus, a neurovirus. It affects the brain and the spinal cord. It is fatal, 100% fatal. And if you catch the patient or somebody who was bitten by a dog early, then post-exposure prophylaxis with 3 injections, okay, it will do the trick. Okay, it's an old disease since the pharaohs they wrote about it. But in 1880, Pasteur, the French microbiologist who discovered the tubercle bacilli, discovered this is a virus. Okay, it's a rabies virus. It's called the Lysa virus, and he even proposed that if we use nervous tissue from a patient, then it contains the virus. If it is the virus is attenuated, meaning to be, not totally killed, okay, but it is half, it can stimulate immunity. It can stimulate immunity. Okay, the it's all over the world, it's not restricted, but because of the care people in Britain, Europe, and America give to the dogs, domestic dogs, then I think the rabies virus is not existent in these countries, because dogs are like children, they are children, so they were looked after very well. And if you want to earn money, you become a veterinary for small animals, okay, dogs and cats. So this is the disease now restricted to African countries, Southeast area, and the Amazonian regions because of the vampire. Okay, if Arwa is there, we can see the three, selected three of those who can give the human being the virus. Okay, the dog, the domestic dog. Okay, and then the vampire, maybe it's going to show. It's already been sent to you in your net, in maybe the email or through the WhatsApp. So these are the dogs, and the tricky one is the vampire. So if you feed bats, bats are usually seen even in houses when they are neglected. So be aware that the aerosolized viruses, which are in the aerosol, issues in the air, okay, can be inhaled, and can infect. So what you need is the virus in the saliva of the animal. Okay, they bite, and the bite is important for entrance of the virus. Okay, can virus get through the skin? Usually no, but because of small aberrations, or if you have a wound and saliva falls on that, then the virus can get penetrated. Okay, the bites have different importance. If a child or an adult has been bitten in the head and the neck, then the chances of getting rabies is very high. It goes down to the hands, less than the head and neck, and trunk is the least if it's bitten. Okay, there is no evidence up to now that by kissing, okay, if somebody kisses an infected person, there is no evidence of transmission. Okay, the intercourse again is not a cause of transmission, and breastfeeding is not a cause of transmission. So if you have bats, then you have to be very careful. If you have laceration and biting by the dog, the first thing you do is to have a very quick detergent soap, just simple soap and water, and leave the water to drain whatever there for 15 minutes. If you have a tap, just put the wound under the tap for 15 minutes, and then that will clear a lot of viruses. Don't suture it, because if you suture it and there is a virus there, it squeezes it into the nervous tissue. So, and the nervous, if you use iodine, again, iodine is a good detergent, it's a good antiseptic, and if there are viruses, it will. So we wanted to reduce the load if the virus is in the saliva, wanted to reduce the load of the virus, and then we apply straight away the post-exposure prophylaxis. Okay, the virus is like a bullet shape, okay, and it goes in the axon of the nervous system, axon and the peripheral nerves. It goes up and settles in the brain, usually in the limbic system or in the substantia nigra brain stem and the spinal cord. So it's brain stem, limbic system, and the spinal cord. Okay, this will lead, to the symptomatology of the virus. Okay, so the pathology is you get encephalitis, you get edema, congestion, some petechial hemorrhages, and lymphocytic infiltration. Okay, the symptoms is aggression. The patient becomes raged, which is, he feels like vigorous, very, very agitated, is completely anxious, and he then falls into the classical symptoms of rabies. And the classical symptom, which is known to occur, is the sudden spasm of the respiratory system, including the neck, okay, and a voice that comes from this spasm. And this spasm is triggered by water somehow, okay, because the patient will have a spasm of the upper respiratory tract. He cannot swallow, and this spasm will give him the anxiety and the irritability, okay, which is characteristic of the rabies. Not only water, even the sound of tap water can trigger it. And then it becomes conditional. Like if you have air passing, it can give this spasm. So the spasm will include upper neck muscles into spasm, the respiratory muscles into spasm, and the diaphragm into a spasm. Okay, and the patient becomes, very rigid, opisthosausis, he flexed back, and then he becomes comatose, or then he becomes stupor or comatose, depending on the stage. But remember that they can have a lucid period. Lucid period is they get flaccid. Everything will become flaccid. And this is important in distinguishing it from tetanus, because tetanus is another cause of spasticity and spasm, but without any relief or hypotonia. Okay? So the encephalitis is furious rabies. That is furious rabies, and this is a word which is you should remember. Rage rabies. This is aggression. Okay, and the patient has, once they have this contraction, they feel like, terror. They feel scared, and they feel like death. Just like something falling from the sky. So this is one type of rabies, which is furious rabies. And then we have the paralytic rabies. The paralytic rabies is the virus goes in and causes hypotonia. Everything goes paralyzed, what we call the flaccid rabies. But the flaccid rabies is not as common as the furious rabies. Okay. Nursing a patient with rabies is a challenge. And here comes the human rights of every patient to get treated. And if a patient with rabies, then you need courageous nurses to go there to deal with the saliva, because once you get the saliva, and there are reports of nurses who got rabies from patients and who died. Okay, but patients, human being, need to be treated, need to be fed, need to be quietened by anti-anxiety, by relaxing drug, relaxing the muscles, which will at least give a good quality, a better quality of life. Okay, so the challenge is these hydrophobic spasm, due to the water. So people will say, well, if you have water, just keep it down, and if the patient has rabies, he will get into a very severe spasm. So these are the two types of rabies, and the incubation period from biting to symptom is between 20 to 90 days. Okay, what shall we do to the dog? If a dog has bitten somebody, he has to be quarantined. You have to be observed for at least 10 days. Okay, he may not be rabid. Okay, but if you give the post-exposure prophylaxis and the dog after 10 days is still alive and very well, this patient the dog has no rabies and there is no infection. Okay, if the dog is paralyzed, and I think I have a picture, if it comes, Arwa, a dog which has rabies will show in these 10 days. It will be paralyzed, especially the forelegs will be paralyzed completely, and then there is salivation, and lacrimation, and the patient obviously, and the dog obviously will succumb and die. Okay, so he has certain paralytic type of rabies. So it was, if you open up the brain, then you can feel the congestion, the lymphocytosis, and all the affected parts of the brain, which is the limbic system, the reticular endothelial system, and the hypothalamus, which is gives you the disturb, emotion, the anxiety, and the worry. Okay, what is the vaccine? The vaccine is an attenuated virus in chick embryo, and this is given in 3 doses. Okay, day 1 of the bite, day 3 of the bite, and day 5 of the bite. Okay, and then it gives very, very good prophylaxis. So 9 out of 10, or even 90 or 99% of the dogs, if bitten, may not cause rabies. But wild dogs, especially, I didn't see wild dogs in Rwanda here. But in Sudan, there were so many wild dogs, eating in the rubbish and on the street, and rabies is there. Okay, so if somebody is bitten by a stray dog, then I think prophylactically you should have the vaccine. I remember of very eminent engineer who is a friend of a doctor. He came to him to say, well, I've been bitten by a dog, which is my neighbor's dog. And he said, no, don't worry. Then he ended up with rabies and he is dead. Okay, there is a lot of improvement on the vaccine. The vaccine even used to be manufactured in Stag in Sudan. And this is the nervous system tissue containing the virus, attenuated, and used to be given on the muscles, the abdominal muscles subcutaneously for almost 10 or 15 injections. I remember them very painful because I have been bitten by a dog, and then I had these 10 or 12 injections, and one of them ended with an abscess. near the umbilicals. Okay, it has to be open. But nowadays, with these injections, which are very handy, with no side effects, and there are only 3 injections which can be given intradermally on the deltoid muscle, on the deltoid muscles. The other complication of the virus is autonomic paralysis. They cause autonomic paralysis, and they may cause either cardiac arrest or respiratory arrest. So the patient dies, maybe he dies of starvation, lack of water because he cannot drink, encephalitis, he may die suddenly from cardiac arrest or respiratory arrest. And then the patient, when he's dead, has to be cared for because the virus is all over the secretions, especially saliva, and burial and washing the patient, cleaning him is a challenge. It needs to have a lot of care before he's buried. Okay. The other differential diagnosis is tetanus. Remember, tetanus is obviously toxins. Tetanus toxins causes spasm, but this is a continuous spasm. Okay, so the patient with rabies, we better give him the patient who was bitten by a dog, even before we know if he's having rabies or not. After we clean the wound the way I outlined, has to be given an anti-tetanus toxoid, which is a vaccine, which is very effective. But tetanus, at the end of the day, gives similar picture. Okay, so with that, I think we have covered rabies. There is no treatment, no specific treatment, and only post-exposure prophylaxis. Okay, with that, I would like to, if the pictures are still there, Arwa. No? Okay. Are there any questions? Dina, Asil, Awad? Are there any questions?
لا شكرا يا دكتور المحاضرة كانت very informative.
Very good. All right. Well, thank you very much indeed for being with me, and we are working on getting it on the YouTube so that you can get it. Anyway, it is recorded, and I'm sure Arwa can pass these lectures to you. Whenever I have time, inshallah, I will do it face to face, which will improve the understanding of all these lectures. Thank you very much indeed, and keep well. Thank you. Bye.